It will be particularly entertaining if I give Dr. Opelka's talk. Every gathering of expert surgeons needs a talk from a neurologist's suit, and so that's what this is. I am glad to be here. Demetrius got me involved, had some early discussion with me about where you all are in your journey, what you're trying to accomplish, and what this setting might provide. I think it's great, for one. For two, I'll be fascinated to see sort of what comes of it. As somebody, a physician executive who's focused not only on bringing groups of docs together, but seeing how and what emerges from that, I'm very interested in how you'll go about that and what actually comes of it. It's a big enough deal just to catalog what everybody thinks and why. It is yet another piece of work to take that material, that information, and synthesize it into work of some sort. The judgments that you make in that activity will be interesting, and so I congratulate you for that. Anytime you bring experts together, that's a positive experience, that's a positive thing. But it comes at a bit of a risk, and we, as we do that inside the system, try to remind ourselves of that constantly. That sometimes the answers to what you're chasing, even in an expert zone, are well-informed or best informed from outside the expertise. This is a visual we use all the time, just to remind us that our own experience, though almost always a positive thing, sometimes severely limits us from seeing what is. The question here is, what are the shades of those two blocks? And the answer is they're the same shade. And yet our experience of all of our lives, of understanding what shadows are and shades are and sunlight is and that sort of thing, absolutely prevent us from being able to tell that that's the case. If you want to test it for yourself, take your finger or two and put it so that it blocks out the interface between those two, and you'll see that they're in fact the same shade. So what's the story there? The story is to recognize that we all have wiring, we all have perceptions, and the pursuit of expertise, though necessary and important and critical, also comes at a cost. And so as you work through this activity, I would encourage you to do the inconvenient thing, do the surprising thing, look for voices from elsewhere that might have something important to say about how you're wrangling through this particular issue, the move within your society to value, or within similar issues, because sometimes the discordant thing or the novel thing or the different thing that someone has to say to you winds up being quite important. What I hope to do in the next few minutes, just a slide or two on who we are, why are we even in this conversation, how we are thinking about the transition. All of these decisions that you're making, even the work that it turns into on a local basis, fits within an overall context of what's going on in our industry, and a specifically important context for you, which is what's going on in your organization. And many of them, most of them, are stressed at this moment. And therefore, understanding how they're thinking and what they're thinking and how to align to that's kind of important. And then I might opine just a minute about your work that you're here to do from a challenges and opportunities point of view. Who are we? We're a health system, large, across 2 states. We're about 30,000 people who provide care in 900 different places in North and South Carolina. The largest provider in each of those two. We're a public nonprofit. That's a rare political animal, but that's what we are. We're the second largest of those in the country. For those who are into money, it's about $8 billion. For those who are into patient encounters, it's about $11 million last year. A surprising part of that $11 million might be that only 5% of that $11 million were in a hospital. And yet people think of us as a hospital company. We're even referred to in reports as the hospital, not even a collection of hospital. And We are therefore reflective. We have everything from a critical access hospital with an average census of 8 to a 1,000-bed academic medical center in a major urban area in a community of 2 million. And everything in between, including primary care, et cetera, et cetera. And so the case can be made as the nation struggles with healthcare and at the industry level, how we go, so goes the industry, and therefore both watching how we're approaching things as well as understanding how the environment is affecting this is a relevant part of the conversation. So you've seen us be in the conversation before. In the past, this would have been a relevant way to say who we are in a fee-for-service or a volume-driven sort of environment. In a value environment, we may choose to talk about ourselves quite differently than that. How many diabetics are we the medical home for, and what is the level of performance of our care of those diabetics? Are we capable of returning to CMS and other payers big savings for avoiding harm and care that didn't need to occur in the first place? Are we capable of seizing on technology and distributing it across very varied environments? Are we capable of harnessing data and using it with a much lower cost to the benefit of patients? Our EMR in and around Charlotte now creates 18 million discrete data transactions a day, with all of that pipeline pointed toward an enterprise data warehouse that now has got 8 or 9 petabytes in it that can be turned around and used real time for the benefit of patients. So I hope you would see, even if you're talking about a health system, in a value environment, how you would choose to talk about yourself is all of a sudden very different than it might have been in a volume environment. And the same would be true about your facility, your group, your practice, yourself. Everyone knows we're in a time of transition. I think your titling here is around transition. Everyone knows we've been in an environment, and what it took to be successful in that environment is ending rapidly. That has served us in many ways, but it hasn't served us in a couple of really important ones. It has been possible in the country to have a great reputation and be mediocre and make plenty of money and sustain. That's been possible within the system that was. That has resulted in care that's pretty good a lot of places, mediocre many places, and cost too much everywhere. When the average American family can't afford the average premium, overall the system's broken and not sustainable, and everyone recognizes that we have to move. There's 100 different charts out there like this that would depict in some way what the move is. One that's unique to your specialty might be interesting to construct. The important thing that I would want you to get from this from a whole system perspective is you cannot make the move from one type of business to the other lest you go through strain. It's not just a fact of life, it's important. And therefore, if an organization isn't feeling strain, then you can make the case you're not moving. And we don't often seek strain or pain or inconvenience or strife. But in fact, to get from one curve to the other, you actually have to do that. You have to have some vigorous disagreements internally. Why? Because you're always leaving money on the table when you move from the safety of the first curve to the inventiveness and the forward-looking aspect of the second curve. You're always giving up a short-term gain for a long-term benefit. Is that readmission that would pay money today really important to avoid or not? Got to have that debate. And there are many debates of that nature. So I bring this up just to say we're going through strain, the whole industry is. Important for, inconvenient. Item number one. Overall, rating agencies say the outlook on healthcare is negative. We are large, capital-intensive organizations with razor-thin margins, and everybody believes declining reimbursement. That's a rough chessboard to be confronted with, and it doesn't do us any good to act like it isn't that stark of an outlook. The question is, what do you do about it, and with conviction? My one comment about this transition thing is the word transition might not be severe enough. We talk about transformation inside the system. I'm not sure transition is violent enough to really depict the disconnection that's going to have to happen between some of where we've been and some of where we have to go. So we ask ourselves these questions. I think it's important to list the questions that you're asking of yourself about your readiness to transform. Some of these are cultural, some of these are traditional, some of these are a reflection of internal values or capability. I think most of the time for groups of doctors, the question is, what do you intend to do? So therefore, the strategy that emerges. And once you decide to do anything as a group, can you in fact get it done? And for many of our colleagues in many specialties, the problem with transformation is the second, not the first. We get agreement about what a measure is. We get agreement about what forward would be. Then we get in a room, we have a bell-shaped curve of opinions around how to actually progress, and it falls apart at that level, right? The check boxes we top out in because we have to do them and we can get around that, but when the debate actually comes back to how are we best going to take care of the septic patient, we have a hard time getting past the autonomy and therefore don't get to consensus action. We get the consensus position. We don't always get the consensus action. I'm happy to talk about quality because for us, for the last decade or so, it's really been the banner under which we've tried to do lots of important things for our system. But we do that up front and intentionally to say, look, quality pursuit for us has to not just be about elevating performance. Not that that's important. Not that that's not important. It is. And if that's all we did, there would be grateful patients at the end of that, and we would be doing good. But in fact, on a strategic basis, we need the pursuit of quality to do more for us than just elevate our performance. And I would assert to you at this moment, you need your pursuit of value and quality to do more for you than just elevate your performance. What your list looks like, up to be debated probably. Here's our list. We're a disparate system with lots of different cultures and processes and experiences. Our pursuit of quality had to be a unifying thing for us. It had to be a standardizing thing for us. It had to be a reason for physicians and others to come together. It's the principal way we can engage docs. If we can't engage them in talking about quality, what can I engage them in? I need to engage them in many things. What's growth look like? What's efficiency look like? What's financial success look like? But in fact, the shortest trip for engagement's around quality, so let's start there. Accountability. If we're ever going to get to each person, each group knows that they're doing their part, and what happens if they don't? Quality's the shortest trip because there's a patient at the end of that. And in the rooms that I'm in and out of, if you can't reunify around the patient, there is no other important unifying force. Had to be a lift for the culture. At the end of the day, we better be able to differentiate because eventually discrimination in those who purchase care of what's quality and what's not's coming at us pretty fast. It's been a blunt instrument so far. It won't always be. And lastly, it had to get us along this move toward value. Many different definitions, many different ways you can think about it. You can talk about different parts of the continuum, different attributes within our system, different specialties coming together. Whatever it is that you're looking to integrate, whether that's a geography or disciplines of medicine. From our point of view, it has to result in all three of those on the right. And that's really what we're pursuing. And there will be some equations where one of those three will be weighted more than the other. But all three, every time, is the answer, I think. And in many domains and in many disciplines, we're pretty good at one of them, we're fair at one or so, and we don't really have a way to get the other one in the picture. And that's not going to help us in the long run, we don't believe, so our strategy is built on achieving all three. Now, we recognize that we didn't think there was any particular place that had the whole answer, and that these things didn't get done in a day, and so we better be about it. And so for our purposes, we created our own internal articulation of what a value, full, integrated health system experience would look like. We called it maturity, because chasing maturity sounded like a good thing, pretty scientific. And we expressed these things and then doled them out around the organization in 15 different working groups, discipline specific, and said, let's go pursue these for 2 or 3 years, because we think doing that would get us ready for whatever the next wave looked like. So I won't talk about all of these, but I'll mention a couple. Number 3, specialty principal coordinator of care criteria developed. That means in most circumstances, we believe that the principal coordinator of care would be the primary care medical home, but not always. When wouldn't it be? Stage 4 heart failure, around the time of a transplant, cancer patient in the midst of chemotherapy, end-stage COPD, end-stage ALS, a number of them. But let's just say we think it's good for the patient that from time to time, the principal coordinator of care isn't the primary care medical home, but it's a specialty-based place. So the practical questions that come back at you is, well, what does that work really entail? Are our neurologists prepared to do vaccinations and other general health maintenance work? Are our cardiologists prepared to get all the consultants' reports in and distribute information to everybody as primary care medical homes would? Do we even know who has the ball? So you see, at the tactical level, what is an overall good thematic? Yes, we need a cardiologist, a heart failure specialist to drive care when you have a stage 4 heart failure. It's pretty simple to say. It's in fact very difficult to execute on. And that's why I say sometimes the execution piece, the actually making it happen piece, is big. But we believe that a forward-thinking health system that is really focused on the patient and is really trying to express the reality that we are best positioned as physicians to understand where the waste is and eliminate it. We will be doing reliably these sorts of things. I think there's a pearl there for you as you consider for your discipline, what are you best positioned to see and help root out, and what would that call on you to be doing regularly and supporting your members in doing regularly. So we measure that. We don't just say we're going to do it. We measure it, and this is how it's gone the last couple of years, that we started at the blue line, and we've slowly, from a maturity point of view, pushed out our boundaries as we continue to tick those things off and make progress. Now, what do you learn here? It's asymmetric improvement. Some people started pretty good and haven't done anything. Others started very slowly and have made great progress. Some had a good first year, bad second year. It varies according to discipline, and why wouldn't it? There's really no consistency in many senses across some of those disciplines that you see there. So my pearl here for you is, even in the thematic, you can turn it into measurement enough to be useful internally for doing a gut check about whether you're really giving it its due as it relates to execution. None of that is in QF acknowledged, right? But it doesn't need to be for this purpose, right? When I think of all the array of improvement efforts toward value that are going on, it's important that we actually hold ourselves accountable for achieving results. These are a few of ours. There are many. As I think about your journey and ask myself the question, if you really want to lurch toward value, if you really want to transform toward value, not just increment that way, what might that look like for you? You know, I think the most proximate things are really deciding what position you want to hold in the care continuum, because I think it's undecided at this point, and it ought to really be something we wrestle with. And secondly, the harm agenda is so close to what you do that I think you have a chance to do that well, do it the best, and actually lead other societies and groups in how well you attend to harm, because the execution phase of working on harm is in fact very difficult. We do it by running continuous internal collaboratives. I'm sure your system, your organization does that as well. The important thing here is we're about to be in a scarce resource moment inside your system and mine. For the last 10 years, if you had a good idea, and Demetrius had many of them, if you had a good idea and you came and said, I think we can improve with this, you likely got funded. Now, of 30 really good ideas, we'll fund 5, because that's the scarceness of the resource related to the ecosystem that we're functioning in. Just a reality, and therefore positioning your work not just about doing good, but how it relates to the work of others inside whatever type of organization you're in, I think is really critically important. We've done a lot of our work with CMS, quite frankly, through first their HEN and then their leading edge advanced practice topics, harm prevention work. We're one of the 5 systems who really bought into that, and I think we gained from it a lot. They gained from it a lot. We returned millions in care that wasn't necessary because it was related to a harmful event. We've made big progress, and still inconveniently, I would tell you, in my organization and in yours, there is every evidence that 1 out of 5 patients who come through your hospital experienced a harmful event while they're there. You might not see it, but it's there. The harder you look for it, you will find it. And that's really ours to own, and we've done an incomplete job of owning it so far. But it won't just be around the typical measure points. More and more we'll have to take responsibility for populations. This happens to be our 65 or 70,000 diabetics on the bottom. And to say it's one thing that they look to us as the medical home, it's another thing to say how effectively are their outcomes at having controlled hemoglobin A1Cs or other pieces. Transparency's coming pretty fast. So here's 2 slides to opine on your work from my position. First, from a challenge point of view, I think you have a decision to make about what part of the continuum you can, are positioned to, and want to own. You want to be a proceduralist and live your professional experience within the walls of that, or do you want to expand to adjacent parts of the continuum with a nod toward being more valuable to the system as a whole than the procedure alone would create? What's proximate to that? Upstream, what's proximate to that is, do you also want to be involved in the work to avoid surgeries or the doing of them on a population level basis? Orthopedists have chased that pretty hard. They're into knee health now, not just knee surgery. I was in Columbus not long ago, saw a billboard that said, Ohio Health, the best knee surgery care when you need it, and only when you need it, which is a shift toward taking some responsibility for the population as a whole. On the back end of it, it is the total postoperative care of the patient, right? You can make a case in some of our hospitals that from a patient safety point of view, it is more important how the medication reconciliation leaving the unit gets done than what went on in the OR. from a pure statistical patient safety point of view. So thinking legitimately, what do you and your members see and want? What role do you want to play, proceduralist versus manager of a whole episode? What's your capability of going upstream and recognizing waste and driving it out and benefiting professionally from doing that? It's incredibly important. You will do it or someone else will. It will get done. The question becomes, what role do you want to play? We know that global measures are immature and they're going to be dirty and divisive, and that's just going to go on for a while. I would say the conviction to not be paralyzed by that fact is really important for all of us. And lastly, recognize that the ecosystem that we're existing in as providers is strained, and it's going to get worse for at least a decade. Consolidations will happen. That won't be fun. That will be muddy. And therefore, support of these things that we want to do will get more and more difficult, because it won't just be Demetrius talking to me about your quality effort. It will be CV surgery and orthopedics and pediatrics and critical care and ED and on and on and on. And the intense competition for support of the improvement efforts will be significantly bigger. But the opportunities are, this is the moment for physicians to lead, in my opinion. You know, the big bet that we're making at the national level is that we providers are positioned beyond anyone else's capability to be able to tell good medicine from bad, waste from not, and to root it out in the interest of the patient and to do well by doing so. But we can't let this moment pass much longer, or some combination of payers and big data and other sorts of methods will begin intruding on the professional opportunity we have. I believe we need to continue, you all are among the most, the aggressive use of technology. We're going to look back 10 years, I believe, and say we went too slow. So we push pretty hard on the use of technology, not just in sort of known technology, scanners and devices and that sort of thing, but even in our daily use. How many patients can you take care of effectively if you're really maximizing the use of technology? A lot more than most of us are, in fact. Reliability is what the safety agenda is all about, and that's a little bit counterintuitive to some of our expertise-driven cultural realities in all specialties. And then you have a unique opportunity both to measure to value and also to create new evidence that others can use and benefit from. Sorry, I went over a couple minutes, but I did 2 talks in one, right? So I think that was it. Thanks for having me.